All right, welcome back. This is part 2 of the stroke lecture. We're moving on into clinically what stroke looks like and then what we need to do. So step 2, once we've kind of begun to understand what could be a stroke, what the different lobes do, now let's understand what clinically, what symptoms do people present with when they have a stroke. Well, the most common presenting symptoms of stroke are aphasias, visual changes, ataxia and or weakness, and then headache, and that's more common in hemorrhagic strokes, which remember make up about 10 to 15% of all strokes. But strokes can present with all kinds of things, ranging from the nebulous and unhelpful confusion to the unique incontinence of a frontal lobe stroke as well as seizure. All right. Now, women may present with different symptoms than men, but they're still more likely to present with traditional symptoms. The other problem with women is they tend to present with more complaints that are less specific. So things like I feel weak and dizzy and nauseous. I'm a little short of breath and I just feel funny. Okay. The problem with this is it tends to make women more likely to be blown off as being dramatic. So you have to be a little bit more careful here. But fortunately, women still are more likely to present with classic symptoms, and the signs are the same. So when you look at this, they're more likely than men, but still unlikely to present with things like unexplained syncope, which is pretty unusual for a stroke unless it's a global or a bleed. Falls or accidents, which can result in pain, right? Respiratory complaints like cough and shortness of breath, or new onset seizures. Now, the physical exam here is pretty straightforward in the basics, but it gets very, very complicated when you think about all the subtle things that stroke can do. Most easily, and where you need to be at your stages, hear them talk, watch them walk, and look in their eyes. You get an incredible amount of information from that. You look in their eyes, you see strabismus. They've got a obvious cranial nerve palsy, right? You look for their pupils. All right, you listen to them talk. Do they have any kind of aphasia? Do they have a normal cadence? Do they have normal prosody to their speech? Okay, watch them walk. Do they have any ataxias? Is there any obvious weakness? Do they swing both arms equally? Do they seem off balance? If you can't get them up, you can always check by grabbing their toe and having them close their eyes and ask, is their toe going up or down? Remember to always grab on the side of that toe, and that'll give you an idea of their proprioception. And then check reflexes. That's kind of a good last thing to make sure they don't have any hyperreflexia. The most frequently missed signs of cortical dysfunction are higher cortical function, things like language, particularly subtle language changes, changes in memory, which we usually don't test, and then awareness and neglect. And this can be very, very subtle if you're not careful and if you're not paying close attention. Level of alertness, okay, GCS, or the AVPU, alert, verbal, pain, and unresponsive or unconscious. Okay, the visual system, so visual acuity, once again, tends to be overlooked. Extraocular movements, which is usually done. Visual neglect, which is and can be very difficult to assess. And then nystagmus, on lateral gaze in particular. And then their gait, once again, this tends to be overlooked. You get the patient up. And I say tends to be overlooked in the emergency department. We tend not to want to get patients up. It takes extra work. You have to be in the room, make sure they don't fall. But you need to evaluate them for ataxia. Have them do a tandem gait, heel-to-toe walking. Check a Romberg. This gives you lots of information. Outside of the neurological exam, the most frequently missed ancillary exam is vital signs. Now, prior to the era of electronic medical records, this was more often because it just wasn't checked. In the era of EMRs, this is often missed because we just don't look for it in the EMR. It's there to get us in trouble, but we don't look. And remember, regarding all of this, you only get credit for what you document. So if you do the test, make sure you make a note somewhere. So thinking about all of these things, neurologically, you cover a lot of ground by just looking in their eyes, hearing them talk, watching them walk. All right, if you check their level of consciousness, extraocular movements, general language, you cover most of the territory from the front to the back and top of the bottom. And a quick, easy way to think about this, by watching them walk, you cover the sensory motor areas all the way down through the cerebellum, the anterior medulla, and down the spinal cord. All right. You add a pupillary and extraocular exam, make a note on nystagmus, questions about diplopia, and you cover the pons up to multiple association areas in the temporal, occipital, and frontal lobes. You add a visual field into the test to test the visual acuity, and you cover the occipital lobe. Right? Now you get all these optical radiations, particularly if you test all 4 visual fields, right? All right, and that covers the occipital lobe, the temporal lobe, and then down under the optic chiasm to the eyes. All right, you stand him up and do a Romberg test, and you're testing the dorsal columns. Lastly, you assess language. Oh, and then I forgot to mention these guys. So watching them walk, general movement, right? And lastly, you assess language. And you're going to assess some parietal and temporal lobe with some frontal lobe. And if you include a note on the quality of their speech, right, the cadence and emotion, you're also going to get the right side, the non-dominant hemisphere. So this really does cover a lot of ground for us. A few examples from my experience, from what I think are interesting strokes I've seen. All right. I had a young woman, as a medical student actually, we had a young woman come in. She was in her late 40s, and she presented with her fiance, who she appeared very comfortable with. She came in with him, seemed to trust him, but when asked, she said she didn't know him. And he actually had the complaint that she'd been acting funny and didn't seem to recognize familiar people, including himself. And they had been seen at another hospital earlier that day and discharged, and they couldn't find anything. All right. Now, a very similar syndrome is seen in Alzheimer's patients. And here's some pictures drawn by one, and you can see how the quality of his artistry deteriorated over time. But these are some similar pictures drawn by people with what this lady had. All right, and I'm kind of throwing you a clue here as to what's going to happen, but you can see all these faces share one familiar characteristic, and that is they're not recognizing the right half of the faces. They're not drawing it, they're neglecting it. Another interesting thing about this woman, and this is where I missed it, is that I did my neuro exam, which was normal, told my attending, he walked in the room, and handed her a pen to ask her to write something. And he held it there, standing on the left side of the bed, on the left side of her body, and she just looked at him. And he very slowly drifted it over to the right side of her body, and she immediately grabbed it and began writing, as he instructed. So she began writing what he had asked her to write, and when she was done, he asked her to read back what she wrote. And she was entirely unable to do this, and seemed a bit baffled that she wasn't able to do it. So she had alexia, an inability to read, without agraphia. Now, this is classic of an occipital stroke, particularly a non-dominant sided occipital stroke. So when you look down here at the picture on the bottom left, you think about that PCA looping back around there. So a proximal occlusion causes something like this. And if you look at the top left, you can see all those optic radiations. I don't really expect you or want you to know all the subtleties of this. Okay, what I do want you to get out of this is always check 4 visual fields: top left, top right, bottom left, bottom right. And the reason for this, as you can see from the top right picture, is that if you annihilate this section of the brain, you get something that looks like this if you're the patient. But they may have neglect and they may have anosognosia. They may not realize that they have a problem. Now, like I mentioned in the first lecture, you tend to look towards destructive lesions. You look at the train wreck, right? You can't take your eyes off it. So the eyes tend to look towards it. This is particularly notable in frontal and occipital lobes, which have the visual areas. And what this produces, as you can see here, is a contralateral visual field deficit. So a stroke on the left, like shown in this picture, will produce a deficit on the right, like shown in the picture at the top right. And you would expect the patient to look towards the left, correct? Because you look towards a destructive lesion. Now, another case, originally made famous by Oliver Sacks in The Man Who Mistook His Wife for a Hat, and what I think is a great case of this, a very interesting, involves a university conductor who began to struggle to recognize his students. And when he came to be evaluated by Dr. Sacks, he was unable to identify, the neurologist, Dr. Sacks, was unable to identify anything particularly wrong with the guy. But on standing to leave, the man reached over to his wife's head and attempted to remove it, as if he were attempting to take a hat off a coat rack. Okay. So at the next visit, when the man walked in the office and Oliver Sacks stood up to greet him, the man walked over to the grandfather clock with his arm outstretched, as if to shake its hand. Now, the man had no idea he had a problem, and he often made simple excuses for his bizarre behavior. So this is called anosognosia, which is to not know that you don't know, right? So to be unaware of your deficits, and this was also a term coined by the creator of the reflex shown here, right? The Babinski reflex. Now, this condition of being unable to distinguish faces tends to be associated with temporal lobe pathology. We talked about that in the previous section of this lecture. And that's also associated in Alzheimer's disease and can result in hemi-neglect of varying degrees, like in these pictures you see here. So the pictures at top were drawn by people with strokes to the temporal lobe, particularly the non-dominant temporal lobe. The man earlier, the artist, drew over time as he developed Alzheimer's. Now, in temporal lobe stroke, because of Wernicke's area being located here, and usually this is an MCA stroke, okay, you tend to have people, particularly in dominant hemisphere strokes, they have fluent or receptive aphasia, so they have difficulty processing auditory information. Because remember, you have your primary auditory cortex here and your auditory association cortex is here. So even if you still maintain hearing bilaterally, you may be unable to identify that a sound is coming from a certain person or object. You may be unable to combine the movement of their mouth and the words coming out of it. Okay. If a sound is moving, say somebody driving by in a car, you may be unable to place it. You may be unable to identify the musicality of a sound. So you may be unable to appreciate music, particularly in the non-dominant hemisphere. And you can have difficulty processing visual information, like the man who mistook his wife for a hat. Prosopagnosia, the inability to distinguish faces. And you also may have problems creating new memories, so anterograde memory, which can create problems learning. And if you think about this anatomically, you remember the hippocampus and the amygdala lie deep within this lobe, and that would explain why. Also remember, these areas are supplied by the MCA, the anterior choroidal arteries, and the PCA. And this accounts for so much of the overlap you see in these syndromes, particularly with these lateral and deep inferior occipital lobe strokes and the temporal lobe strokes. Now, one last example to kind of give you an idea of how important the lobes are in stroke-like syndromes is another classic from neurological history, and that's of Phineas Gage. So this guy was a hard-working, dependable railroad worker, and he had the unfortunate luck of being impaled through the forehead by a tamping iron while working on the railroad. Now, prior to the event, Phineas Gage was a hard-working, well-respected man. And after the accident, he was noted to be impulsive and unmotivated. He was unable to hold down a job. He kind of became a transient. There's some stories suggesting that he had volatile behavior, but that's probably just history getting the better of the story. But certainly he had some changes in personality, and particularly in planning and the ability to be motivated. Also, very interestingly, he walked himself from the site of the injury to the physician's office and had a fairly fluent conversation with the physician about how exciting this was going to be. So these can be very peculiar strokes where people maintain most of their function otherwise. And this is a rendering of what probably happened, where the damage was in Mr. Gage's frontal cortex. So now that we've kind of gone over a couple of examples, we've reviewed what can be a stroke, what the lobes do, we need to make sure this isn't anything else. So what are stroke-like symptoms, or stroke mimics? Now, this is common in stroke literature. This is frequently fought over, all right, largely because this remains one of the last methods that skeptical ED physicians have at their disposal to refrain from giving a patient the infamous clot buster, TPA, because most of us don't really agree with it. And this can include things like seizures, which is the most commonly misdiagnosed entity. Okay, which means they're diagnosed with a stroke and it ultimately turns out to be a seizure. All right, there are several other things that can cause this as well. Overall, the frequency of stroke mimics varies from about 6% all the way up to 20%, so it's somewhere in there, which means somewhere between 6 and 20% of these folks actually have something else when it's called a stroke. Now, remember when we talked about in the first lecture about definitions being important? This is why. If you remember the study that quoted this may be the only time in modern stroke literature you see anybody using the WHO definition. But here, in this one instance, it's useful because it allows you to say that contrary to all the other literature in which an imaging definition is used, so that we can include all the TIAs in our stroke treatment. Everyone here that we thought was a stroke clinically was a stroke. So otherwise said, I think I'm right, therefore I am right. Now, stroke mimics are myriad and include everything from Todd's paralysis, which we've talked about in the seizure unit, to multiple sclerosis, to encephalitis, vertigo, malignancy with compression, hepatic encephalopathy, other encephalopathies, there's encephalitises, cardiac failure, right, because you can have diffuse hypoxia, complex migraines. So there's lots and lots of things that can do this. So we kind of need a framework on how to deal with this. You're going to start with hypoglycemia because it's the easiest to figure out and the easiest to treat. And what you're going to do is get a finger stick. Now, remember, hypoglycemia can result in confusion, altered mental status, altered behavior, seizure, coma. It can also result in focal deficits such as hemiplegia or hemiparesis, or even aphasia, especially if it's associated with a right-sided paresis, which sounds a lot like a left-sided MCA stroke, right? So you get your finger stick and that'll rule that one on out. Also note that hyperglycemia, and particularly things like DKA or hyperosmolar hyperglycemic non-ketotic states, can cause a metabolic encephalopathy. And it can result in things like homonymous hemianopsia or hemiplegia or hemisensory deficits or aphasia, again, sounding a lot like an MCA stroke. Okay, so a really, really elevated glucose can also do this. All right, so moving on. Complex migraines. So 25% have focal neurodeficits on a really thorough neurological examination. Now remember, these things have a similar causative function as a seizure, although in this case, instead of cortical excitement, it's cortical spreading depression. But there is something called a hemiplegic migraine, which is a kind of migraine. It sounds exactly like what it is, where you have hemiplegia. Once again, looks like an MCA kind of stroke. Now, these kind of migraines tend to progress throughout the patient's lifetime, so you get gradual worsening of visual, sensory deficits, aphasia, cerebellar symptoms. These people may have a headache without symptoms. They may have the hemiplegia or the visual or sensory aphasic symptoms without the headache, which means this looks exactly like a stroke. But these people should have a history of a migraine. All right, these can cause permanent changes. And the few times that we've had the good fortune to do an MRI during a migraine, you can see that cortical spreading depression, and sometimes you can see what looks like stroke-like changes that then resolve, almost like a TIA, but no underlying thromboembolisms found. All right, the difficulty with these is that these put you at a bit higher risk of actually having a stroke. All right. Other things like demyelinating disorders, so multiple sclerosis, leukoencephalopathy, like from viruses or medications or ingestions, can cause these problems. This can cause hemiparesis, cranial nerve palsies, visual changes. And a quick note on multiple sclerosis, there's a small subset of patients that can have brief paroxysmal symptoms like ataxia, dysarthria, diplopia, sensory deficits, things that look exactly like a stroke, right? But most commonly, the initial presentation of these, and remember this is only 15 to 20%, but it's still the most common initial presentation, is called optic neuritis. And this is a visual field loss, an afferent pupillary defect, right? So you shine the light in it, doesn't react, and loss of red vision, which is a less commonly known part of this. Once again, it looks a lot like a stroke. Remember the JC virus, which is associated with immunocompromised people, and progressive multifocal leukoencephalopathy can result in stroke-like symptoms. All right, now these things in association with seizures are usually elicited by history. Now, vertiginous disorders, which can also masquerade as strokes, can usually be hashed out by a HINTS exam, which we talked about in our dizziness lecture, right? So history and the HINTS exam knock these guys out. Now, a quick side note on dizziness. We're just going to review in relation to stroke. Remember, if somebody has tinnitus, so ringing in their ears, hearing loss, and vertigo, we most commonly think about Meniere's disease, particularly if there's a fullness in their ears. But you can also have these things with an AICA infarct, right? Now, at your stage, you're going to have all the other symptoms. You're going to have other cranial nerves deficits. You're going to have crossed motor and sensory findings, right? But realize that an AIC infarct can look this way. Acute spontaneous vertigo Okay, so acute vestibular syndrome, we usually think of vestibular neuritis. That's the most common cause, but this can also be a cerebellar or a PICA infarct. Once again, at your stage, you're going to think about things like dysphagia and dysphonia because you're going to get all these, like the vagus and the glossopharyngeal nerves. Now, if you look over here on the right, this was taken from a Mayo clinical proceedings study that looked at dizzy patients presenting to the emergency department with dizziness. And out of almost 1,000 patients, only 49 or 5% had serious neurological disease. This included ischemic stroke, TIAs, hemorrhage, seizure. Okay. And when they looked at it, only 2 patients out of almost 1,000 had serious neurological disease and isolated dizziness. One of those was a hemorrhage and one was a TIA. Now, 1 out of 24 of the ischemic stroke diagnoses were a dissection. Okay. Furthermore, 20% that were ultimately evaluated by a neurologist, so referred on to a neurologist usually within the ED visit, had a serious cause. 1 out of 5. We did pretty good, I think. 2% that we didn't get a neurological evaluation on, so 11 out of almost 1,000, ended up with a serious disease. So we still missed several, but not many. And 10% had other serious disease. They were going to get put in the hospital anyway. And ultimately what this study found was that if a patient's over 60 years old, if they have imbalance or ataxia or any focal neuro exam, then you need to work them up or at least need to be concerned about a central cause of their dizziness, otherwise known as seizure, right? Okay. Back to our differential. Moving on, we're now down to seizures, masses, your encephalopathies, and functional hemiparesis. Now, your masses, you're usually going to rule out with a CT scan. All right, so that helps there. For things like hyper or hyponatremia that can cause metabolic encephalopathies, as well as your hepatic encephalopathy, you're going to get labs. All right, and these can cause focal acute neurological changes that resolve when you resolve the problem. So it's something you need to look for. So we rule those out, and now we're left with seizures and functional hemiparesis. Now, seizures are the most common stroke mimic. Okay, and think about our seizure lecture. You can have focal seizures that cause hemiparesis, that can cause gaze deviation, decreased mental status. Even worse, you can have TODS paresis, TODS postictal paralysis, which is a post-seizure deficit that can last up to 48 hours after a seizure. So particularly in somebody who had an unwitnessed seizure, this can look exactly like a stroke and have persistent symptoms. And when you look at the stroke mimic studies, if they use a clinical definition, they could be defining TODS paralysis as a stroke based on a clinical definition. Okay, so this can perfectly mimic a seizure or a stroke. And so the clinical history is incredibly important here. And so lastly, this brings us to functional hemiparesis. And lastly, because this is a diagnosis of exclusion. When you've gone through all those other differentials and you've established you really don't believe it's any of those, and it doesn't appear to be a true stroke, then you can diagnose functional hemiparesis. Functional hemiparesis is a somatoform disorder, which means it is a mental illness, but it causes real bodily symptoms. And people with this, so for instance, a hemisensory loss, you can stab these people with an 18-gauge needle until they bleed, and they really can't feel it. Now, it's kind of like when somebody gets ketamine, all right, which is kind of a cousin of PCP, all right? They're kind of dissociated from it. So they don't actually have any problem with their nerves, but they're not processing this right, even though there's no anatomical reason for them not to. So they can look exactly like a stroke. Now, my brother actually saw a patient with this, or at least a cousin to this, and it was a woman more with malingering type symptoms, but she would move her arm. She had a hemiparesis. She would move her arm when everybody was out of the room and when she was talking to her husband, when she wasn't thinking. But then when you walked in the room to examine her, she said she couldn't move it at all. Okay, she had preserved reflexes and an otherwise normal a neurological exam. And the reason I mention this is because ultimately the neurologist elected to give her TPA, which has the known risk of a bleed. And this is sometimes what you see in these stroke studies. You have to remember sometimes they are thrombolizing people who have TIAs and people who have functional hemiparesis. And you would expect these people to, on average, do better because they don't have a functional problem that's being treated here. So when you see positive results in these stroke studies, this is another reason why they're probably biased towards being successful in the study. So anyway, that was a caveat. Before we do anything else, okay, there's a few things you have to do up front. A finger stick blood sugar, electrolytes, an EKG, a troponin, a PTINR, just in case you're going to treat, and then things like urinalysis, chest x-ray, maybe an LP if you think there's an infectious cause, right? So these are your big tests that you need to do up front. I would really emphasize the finger stick blood sugar. It tends to get forgotten and is a really big missed cause of stroke-like symptoms. So we've gone through this. We think this is a stroke. We've gone through our differential. It's not anything else. Now, make your patient feel bad. Grade them. And we grade stroke patients with the NIH stroke scale. That's the National Institute of Stroke scale. And this gives us some idea of how bad, in general, the stroke is. Now, the elements of this are we assess their level of consciousness, their visual and sensory motor systems, their speech, and then we evaluate them for evidence of neglect. This needs to be done on every stroke patient on arrival to the department, because this does two things. It gives us an idea how bad it is, and also if they improve or deteriorate, we have some objective way to measure this. And what you need to know right now is scoring the NIH. Even most of us residents and attendings at the hospital are going to pull out an NIH paper, and we're just going to march down the list. But you need to know what it means. Now, ultimately, if they score less than 4, the stroke's considered mild, and usually this means we don't treat them, we just watch them. If the score is over 22, it's a severe stroke, and once again, we don't tend to treat them because the concern is they're going to do poorly no matter what. Now, again, the caveat here that I think is interesting is that the therapy that we have, so TPA or alteplase, doesn't really perform well in people with bad strokes, which, if you think about it, is a little interesting. You would expect if this actually breaks up the clot, it would do better in worse strokes. But it doesn't. It tends to do much better in people with mild to moderate strokes, who you would expect would do better anyway, right? So the 4 to 22 group is the money shot. If you're going to do TPA, if you like it, if you drink the Kool-Aid, this is where you give your TPA. So this is why it's important. So now, step 5, because you're not busy enough being a doctor, filling out paperwork, complying with government regulations, filling out paperwork, let's casually ruminate about where the stroke might be located while ordering the CT to rule out a head bleed and then an MRI to confirm your suspicion, right? So this is the more academic side of things. Now, we've already talked about frontal lobe and parietal lobe, temporal lobe, occipital lobe. What happens when you have deficits in those areas? Now let's talk about vascular distributions. So the middle cerebral artery, and remember, these can be incomplete. It's a large artery that then spreads into a large territory, has a very large distribution. In general, this causes contralateral face and upper extremity weakness and numbness. Okay, you tend to have a lateral gaze preference toward the lesion, right? We look toward destruction. Okay, that's called conjugate eye or conjugate gaze deviation. You can get a hemianopsia from this. And this is because you damage the optic radiations that pass through here. Okay, you could also hypothetically get a quadrantanopia, or a quarter of the vision could be affected. Remember, the MCA goes to the temporal lobe, and so you can get behavioral changes. You can get problems with the hippocampus, so memory, and the amygdala, so emotion. These people tend to have agnosia, so they don't know or can't process sensory information, because remember, all of the visual, auditory, and sensory association areas, they can have very unique kinds of apraxia, or inability to perform certain movements. And anosognosia, they don't know, especially on the non-dominant, usually right side, they tend not to know that they have a problem. So quickly remember what the anatomy looks like here. Remember your MCA distribution, what it looks like on the brain. It covers a large amount of territory. And remember, we talked about the parietal is very lateralized. So a dominant, usually left-sided MCA stroke, which does get the parietal, can cause Broca's aphasia. Now that's more frontal, and Wernicke's aphasia, which is parietal and temporal. Okay. Remember that Broca's aphasia is an expressive aphasia. It's the inability to produce language, and this is spoken or written. You can't find the right word. Wernicke's aphasia is a problem with the fluency of language. You sound fluent, but you can't make sense of your language. You can't understand language, you can't comprehend it, and you can't produce comprehensible language. The dominant MCA can cause anosognosia, not to know that you don't, or that you, so not to recognize your deficits. It can cause contralateral neglect. And it can cause you to draw or copy poorly, and this is part of the reason that one of the tests we do is have people draw an overlapping like square and circle. Okay, because people with non-dominant hemispheres typically can't do this. Some examples of this, so Broca's aphasias here on the left. When one of the NIH stroke scale questions is, please describe this picture. So somebody with Broca's aphasia can only say cookie jar, fall over, chair, water. They can describe individual elements of this, but they can't actually fit in the intervening words. They have no ability to create a full grammatical sentence. Wernicke's aphasia, on the other hand, is fluent. They can speak fluently, but it's garbled. So they can say, well, this is, mother is away here working her work out of here to get the better. But when she's looking, the two boys look in the other part. One they're small, the into her time here. And you can understand that sounds pretty odd. All right. They also have problems, as you can see in the bottom right, naming things. So this is a dominant hemisphere MCA lesion. Non-dominant hemisphere, we've gone over this, agnosia. To not know, so visual agnosia, to not recognize visual things. Okay, prosopagnosia, not to recognize faces. All right, they draw and copy poorly. Okay, things like this. They can have neglect, and as you can see in the top left, they neglect the left side, which is more common. They can have problems with maps and putting things together in a coherent way. So you see the truck at the bottom right. You can see the patient neglected the left side of the clock up here. Okay? So problems with spatial things, problems with spatial recognition of things and where they should be related. These are the elderly people that may get lost walking around their own neighborhood, okay, because they suddenly can't put together the space around them in a meaningful or comprehensible way. And you can understand how this would be difficult to find on an examination if you weren't specifically looking for it. This was another, I think, kind of interesting example for me. You can see that this patient just ignored the left half of the page. They were asked to circle and cross certain triangles, and they just completely left the left side of the page open. This guy had a more interesting deficit. Okay, he was asked to circle complete circles and cross out objects that were incomplete circles. And as you can notice, he circled several things that look like a backwards C because he had neglect of the left side of objects, and so his mind filled them in. He just didn't even notice that that was an incomplete circle. So you can even have neglect of parts of objects. Moving on, an ACA, an anterior cerebral artery infarct. Remember, this gets a lot of the frontal lobe as well as parts of your somatosensory and somatomotor cortices. So you can get altered mentation and confusion because of that frontal lobe damage. You can get impaired judgment and insight. This is an unusual lobe in that you can get some primitive reflexes like the suck reflex or grasp reflex. You can get bowel or bladder incontinence, which is the same as a frontal lobe seizure, all right, and is very unique to this lobe. You can get unilateral lower limb weakness, and this is really the key here, and hyposthesia or paresthesias. You can get apraxias. These tend to be motor apraxias or motor hemi-neglect, so the inability to perform purposeful actions. Now, you get this also with parietal lobe problems, so MCA problems. This tends to be a different kind of apraxia, and one particular kind is motor hemi-neglect. So, and this is the kind of apraxia where you are kind of a boy or a girl on a string. You can't make yourself do certain motor functions, but when commanded to do them, you'll follow orders. This is a little different than what you see in the parietal lobe. Once again, kind of an interesting stroke. Moving on, lacunar strokes. Now, these tend to be bleeds. They tend to be intraparenchymal or intraaxial bleeds. These are associated with long-standing hypertension and older age. You can see these come off the MCA primarily, and they result in a pure sensory or pure motor syndrome. Okay, this is the one that I tend to see the most. These can also be subacute, and they can be incidentalomas. You can find them incidentally while CT scanning somebody's head for another reason. All right, sometimes they never even knew they had it. Charging ahead, carotid dissection in particular. So carotid dissection, and this is one of your cervical arteries, right? Your carotid and your vertebral. You've got headache, unilateral neck pain, or face pain. This tends to happen in younger patients and associated with trauma, but the trauma may be fairly minor. Can be from turning a head, snapping a head. If you get spooked, it can be a chiropractor manipulation. And this can result in hemiparesis or hemianesthesia of the contralateral body, just like you would see with an MCA stroke. Remember, the carotid primarily supplies the ACA and the MCA. And so you can get deficits with either of these depending on how that dissection propagates. If it embolizes off or if it occludes the entire carotid artery, you can get a decreased level of consciousness. Once again, primarily because of its effect on the ACA. You can get aphasia if it's a left-sided carotid artery. You can get a monocular field deficit because remember, the first artery off the carotid artery is the ophthalmic artery. And you can get Horner syndrome. And you can get pretty much anything else on that side of the head. Now, you can also get carotid thrombosis or embolism, and this tends to be older patients with vascular risk factors. This is why you listen for carotid bruits, which is not a great test, but it looks good on a chart. Symptoms can basically be anything in the ACA or MCA as well, and this tends to be a stuttering or gradual course for the same reason as the dissection. Only these patients may not have the antecedent history of trauma. Moving backwards into the posterior circulation, the PCA. Now, we had an example of a PCA stroke in our younger lady from earlier. This can present with a headache, particularly because of swelling down here by the cerebellar tentorium. It can cause herniation, downward herniation here. You get visual field deficits almost uniformly. If it is a left occipital stroke or a left PCA stroke or a dominant right, then you tend to have difficulty reading. That's alexia. If you have a right or non-dominant hemisphere PCA stroke, you tend to get visual neglect and disorientation to place. You can also have difficulty identifying faces, so you can get visual agnosias, particularly if you suffer damage to the projections into the temporal visual association area. So you can actually see some prosopagnosia and general visual agnosias from this. Remember, the classic finding here, particularly in a left-sided, is alexia without agraphia. So an inability to read, but you're still able to write. Moving down, we come to the basilar artery. Now, this artery feeds the AICA and the PICA, which we talked about in the dizziness lecture, as well as the penetrating branches that supply the pons and the medulla. So for the sake of statistics, I'll include the PCA in this because it's technically posterior circulation. And given this, 20% of strokes involve the basilar and posterior circulation. So this is probably important to be somewhat familiar with, right? Now, in general, excluding the PCA, syndromes here can be variable. They usually involve cranial nerve. So anytime you see a cranial nerve deficit in association with some other problem, a focal neurological problem, you need to think of basilar artery stroke. It can be cerebellar symptoms, neurosensory tracts. They may have a loss of consciousness because your reticular activating system moves through here. You can get nausea and vomiting. You can get visual changes, but usually these are like diplopia, right? Because of your the location of your extraocular nerve nuclei. You can get some agnosias here, alexia, particularly up higher, like with your PCA and your superior cerebellar artery. You can get a homonymous hemianopsia. You can get visual neglect, right? You can get altered thought processing, right? So lots and lots of bad things. Basilar artery occlusion, pure basilar artery occlusion causes locked-in syndrome, which means you can move your eyes up and down, but not left or right or any other direction. That is the only movement you have in your body, but you've otherwise a preserved sense of consciousness and can think normally. If anybody's ever read The Count of Monte Cristo, there's an interesting character with this. So this has been known about for centuries. We've talked about these, so this is an example of the pontine vascular distribution. Any infarct down here is going to cause cranial nerve deficits. We've gone over these before. We're going to go over them here in just a minute. Here's a large list of your vertebrobasilar problems of vertigo, diplopia, visual field deficit, spasticity, right? But more simply, and what I really want you to remember, crossed findings, so motor on one side and sensory on another. You get cranial nerves. You get ataxia without vertigo, particularly because of those cerebellar peduncles coming in, right? And the 5Ds, diplopia, so seeing double, dysarthria, talking funny. Okay, not aphasia, not a problem with words, but a problem producing them with the muscles of the mouth. Dysmetria, which is kind of like ataxia, right? Inability to move rhythmically. Dysphagia, difficulty swallowing, and dizziness. Now, let's talk about AICA and PICA quickly. Wallenberg syndrome, let's review. So crossed sensory and motor findings. It is a brainstem finding, right? It is in the pons, low pons, and in the medulla primarily. All right. Here's a quick review of this. You get nystagmus, ataxia, hoarseness, dysphagia. This suggests that it is medulla. And then you can get vertigo. This is more complicated than you need to know, but this is the areas of damage. Probably good at least to read over this. All right, and what they each cause. You can also get Horner syndrome with this. Okay, AICA syndrome is the PICA syndrome plus tinnitus plus hearing loss. All right, that's the easiest way to remember this. Just remember cranial nerves, crossed findings. That's what you guys are going to need to know for now. You can get more detailed as you go along. If you have a mural or embolic source, okay, so if you have a clot in the heart, whether that's like we talked about in the first lecture, septic emboli, so you've got bacteria on the heart valves, whether that's a clot from atrial fibrillation. If something is embolizing off, you can get multiple lesions in the brain in various vascular distributions. These can be very difficult to identify up front because the patients can have very inconsistent neurological exams. You need to pay attention to this, and anybody with atrial fibrillation, prosthetic valves who's not anticoagulated, or IV drug user with infective endocarditis. Okay, like I said, these tend to be sudden onset with staggered symptoms. Now moving on, so we've gone over TIA where a stroke resolves, a stroke where the stroke gets worse and worse and then levels off, or maybe it gets a little bit worse if it's like a thrombotic stroke. If the symptom density just continues getting worse, you need to worry about a bleed, okay? Now remember, a large stroke can have some edema, and so it can have gradually worsening symptoms, but shouldn't be significantly worse. In this case, you really need to be thinking about bleed, and that's why we get a CT scan, right? So if you're wondering why, just get the CT scan. But really, we're trying to rule out a mass and a bleed, right? Now, you may be thinking, do I really need to get a CT scan? Doesn't my clinical exam tell me? Well, maybe. Things like seizures, vomiting, severe headache, loss of consciousness at onset of symptoms, history of anticoagulation, all right? Those may be helpful. Things like upgoing toes or neurodeterioration in the first 3 hours of symptoms, highly elevated blood pressure. Okay, those all suggest that you have a bleed versus things like a history of TIAs, diabetes, history of angina or claudication. So we know you have vascular disease, a cervical bruit, all right, or no neurodeterioration. That would suggest that you have a thromboembolic source. But the problem is these aren't perfect. At best, you have seizures with a likelihood ratio of 5, which is really pretty modest. So at the end of the day, just get the CT scan. These are sick patients. And this is pretty easy, right? I mean, you can see the white on all these, which is bleeding, except when it's not. So these are all intraventricular hemorrhages on the bottom left. All right, a subarachnoid on the bottom right. And then on the top, this is all subdural, actually. And remember, there are other reasons to get a CT scan too, like masses. Now, ultimately, the sensitivity of a CT scan for ischemic stroke is about 50% within the first 24 hours, and about 75% if it's like a large proximal MCA within the first 6 hours. But even then, you rarely see it before 4 to 6 hours. And overall, in a community setting, so without a neuroradiologist reading it, CT is about 25% sensitive in the emergency department for a stroke. And an MRI is about 80% sensitive. All right. Furthermore, there's this problem of your differential diagnosis from radiology. And these are things I don't expect you to know, but you need to be aware there are other things that can look like a stroke, like a Virchow-Robin space or perivascular space. And this is just, this is what it sounds like. It's a perivascular space around the blood vessels in the head that can grow quite large. They're not actually a stroke, but they can actually cause some compression of the structures around them and create stroke-like, usually mild stroke-like symptoms. All right, some other CT mimics. Here's some more examples of. Here's another example of subarachnoid hemorrhage, and this is a fairly subtle finding. These are cavernous malformations. Okay, these tend to be thin walls. They may bleed. And here's an example of multiple sclerosis lesion. So, quick note on intracerebral hemorrhage, because this is one of the big differentials you have to rule out before you give somebody TPA, because the side effect is it makes you bleed. And if you're already bleeding, that's really bad. So these tend to be sudden onset, worst headache of life. There may be a loss of consciousness or decreased level of consciousness, vomiting, secondary to increased intracranial pressure, and these people tend to be hypertensive. So these are all the factors you need to look for and consider in somebody with stroke-like symptoms. Now, most commonly, the most common intraaxial, so inside the brain, or parenchymal hemorrhage, is a putamenal hemorrhage. It's the only one we're going to talk about. It's the most common cause. About a third of these are in the putamen. It can cause hemiparesis, partial or complete. It can cause dysarthria because of its effect on the cortical bulbar tracts. It can cause coma, once again, because of its nearness to the reticular activating system and its inability to actually cause herniation and compression of that area of the midbrain and pons. It can cause decerebrate posturing. And these tend to have rapid progression, once again, typically because of herniation. So within hours, maybe minutes. These are very, very dangerous. These are the people that you get a call of a code blue from the CT scan. Remember where your putamen is? Okay. And basically this area over here, the bottom right, is what hemorrhages. You can see on the color picture what it affects the putamen, sometimes the globus pallidus, the caudate nucleus. All right. And otherwise, here you see your corticobulbar tracts and then your corticospinal tracts here. When you have a hemorrhage, it can affect all of these things, right? It can even affect the thalamus to some degree, depending on how big it is. And there it is again in your internal capsule. Now, if you do have a hemorrhagic stroke, whether it be a subarachnoid or something like a putamenal, all right, what do you need to do? How do you need to treat it? Well, you want to lower the blood pressure to 160/90. This is one of the few times we're actually going to lower the blood pressure, all right, because the high blood pressure means high pressure, pushing blood out into the brain, causing a worse hemorrhage. So we're going to lower that down. And these are the things you can use. This is from a resident lecture. What I really want you guys to think of now is your antihypertensive. So you've got your ABCDs of antihypertensive. So A for ACE inhibitor, B for beta blocker, C for calcium channel blocker, and D for diuretics. Now, diuretics take a while to work, so we're not going to worry about those. But your ACE inhibitors, like enalapril, your beta blockers, like a labetalol, which can be IV, or your esmolol, which can be an IV drip, which is why it's useful. You can turn it off and it has a short half-life. And nicardipine is your calcium channel blocker. And that may actually prevent some cerebral vasospasm. So your ABC of antihypertensive are good to remember in these patients. You also want to do your normal things for any kind of head injury patient. Elevate the head of the bed, protect the airway, because once again, if they herniate, they're going to stop breathing and they're going to die. And give them things like mannitol and hot salt. Clearly nothing by mouth in case they vomit and then aspirate. And these people always, always, always go to the neuro ICU. All right, before we finish up. So we decided this isn't a bleed, and it doesn't seem to be resolving, so it's not a TIA. What's the chance this is a mimic is a question we've already discussed we need to ask. And what's the chance this will end badly if I do nothing or if I give TPA? To understand this, you need to know a little bit of background. So the definitions and scales of things that are used clinically and experimentally. We've already talked about the NIH stroke scale that'll give us a clinical idea of how bad a stroke is. What they use in research and why it's not reliable is called the modified Rankin scale. This is what it is. It basically ranges from no significant disability despite symptoms all the way to dead. And when they've studied this, it has an awful kappa value. And a kappa value is basically how often two people agree with each other, or sometimes how often somebody agrees with themselves. And when you have the same neurologist evaluate a patient twice, they have a kappa value of about 0.72, which translates to moderate level of agreement, which means about half of the data that they produce is reliable. So it's not very good. Another thing you need to consider in somebody who you've established probably has a stroke is, do you have a neuroradiologist reading that CT? We talked about how subtle those findings can be. The other question is there a rapid MRI available to confirm a stroke? But then you have to ask, am I going to use a clinical definition or an imaging definition? All right, now, what do the guidelines say as far as treatment goes? Well, it depends on who you ask. The AHA-ACC, American Academy of Neurology, American College of Emergency Physicians, they all have subtly different guidelines. So what does $11 million buy? Well, for the most part, they agree. We're going to use Alteplase or TPA. We're going to give it in this dose. Once again, this is a residency lecture. You guys need to realize up front that this is the contraindication list, and there are lots of them, and that's because it causes bleeds and lots of problems. So following the protocol in this is a bit difficult. Our college, American College of Emergency Physicians, tells us to give this to patients, green being good outcomes and red being bad. So they say out of 18 people who have a stroke, 12 are going to do bad if you do nothing, and 6 are going to do good if you do nothing. If you give them TPA by the NINS criteria, and we'll talk about that in a minute, 2 more will do better, and 1 will die. But what this really needs to look like is this, because doing good doesn't mean they completely resolve. If they completely resolve, that was a TIA. It just means they do okay. They have a reasonable outcome. So instead of good recovery, we should probably say some degree of recovery. So 8 will have some degree of recovery, 1 will die, and 9 will still have a bad outcome despite the fact you treated them. But this is the crazy stuff that we read, and I'm not going to read this all, but basically this is out of the ER Bible, and they say that we should all be giving this all the time because clearly it's good and you're going to get sued if it's bad. And it's a lot of rhetoric aimed at encouraging us to use this. Now, as Mark Twain said, there are lies, damned lies, and statistics. And the data and the controversy of this revolve around the 12 original studies. There have been many more since, but this group called the NNT, and if anybody hasn't looked at this, I suggest you do, but this group called the NNT has looked at this, and they established that there are no benefits. And there are for sure harms, probably 1 in 20, harmed by symptomatic intracranial hemorrhage. And what do they base this on? Well, there were 2 positive studies, NINS-2 and ECAS-3. As you notice, the 2 and 3 aren't just for fun. This was the 2nd and the 3rd study in this series, which means that 1 and 2 studies were negative, but they just kept on trying until they found something that worked. Now, this contained 1,154 patients between the 2 of these, and the NINS study demonstrated that this works, although there were lots of methodological problems there. And the ECAS-3 demonstrated that it doesn't work in the first 3 hours like the NINS-2 said, but it does work between 3 and 4.5 hours. And once again, there were lots of methodological problems, one of which was that the control group was a lot sicker than the experimental groups, so you would have expected placebo to do just as well. Now, there were 6 studies, okay, and these were done anywhere between 1995 and IST3, which was 2012, and that contained 5,500 patients, 5 times as many as the first 2. And these all said there was no benefit, although IST3 said that there was a non-statistically significant benefit. And everybody keeps jumping on that and combining it with the first 2 methodologically flawed studies to say this is great. And then there were 4 studies that had 1,400 people in them. So more than in the 2 positive studies we have, and all 4 of these were stopped early due to harm, namely death and intracranial hemorrhage. Okay, and despite all this, we've continued to push the use of TPA for stroke. So what should we do? And this is my opinion. Clearly, I disagree with the guidelines here, but aspirin. We need to give aspirin. We need to manage blood pressure, but not carefully. 220 over 120. This is one of those where you really let that blood pressure ride high because they're probably trying to perfuse that brain. And then good post-stroke care. There's lots of studies that suggest having a great stroke nurse who really works hard at their job to make sure that these people get swallow studies and they get physical therapy. That probably does more for these people than anybody. It also confounds a lot of the studies on stroke now because people that get TPA are also much more likely to end up in a stroke unit and get great stroke post-care. The other thing I think is worth mentioning, when you read books like Bradley's Neurology, they say things like this: steep decreases in stroke incidence and mortality have occurred in industrialized nations. In the United States, it's been attributed to a declining stroke incidence. Lower case fatality rate with suggestive evidence favoring a trend in declining stroke severity. We're getting better because the strokes aren't as bad. And we're attributing this to dietary and lifestyle behaviors, different patterns of risk factors, and environmental conditions, not because of TPA, which I think is fairly telling. So anyway, that's just a little caveat onto stroke treatment. Overall, this is a very complicated issue. I'm sorry this took so long. Hopefully you learned something. These are my sources, and this is a quick review of what all the different strokes do, very, very briefly. So thanks for listening, and that is the end.